Welcome to the audio digest of the American Journal of Psychiatry. This is Dr. Susan Schultz with highlights for the month of April 2008. Please note that the full text of all articles may be viewed online at ajp.psychiatryonline.org, including all author affiliations and disclosures. We'll begin with our new feature, Education in Psychiatry. This month, Carolyn Douglas describes how to teach supportive psychotherapy. Then we'll turn to a clinical trial reported by Graham Emsley and colleagues, who studied continuation treatment with fluoxetine for children and adolescents whose depression responded during short-term treatment. Next, we'll highlight a trial conducted by Nancy Bloom and colleagues of a group treatment program for borderline personality disorder. An editorial by Kenneth Silk will also be included. Then we'll turn to 3 studies of schizophrenia. Takanori Hashimoto and colleagues report on regional expression of GABA-related genetic transcripts in the neocortex of patients with schizophrenia. Monica Rice and colleagues examined the relationship between cannabis use and loss of brain volume in schizophrenia. These 2 articles are discussed in an editorial by Editor-in-Chief Robert Friedman. The 3rd article on schizophrenia is by Alan Sanders and colleagues, who carried out a genetic association study of 14 candidate genes. We'll conclude with a report by Christoph Fair and colleagues on the association of nicotine dependence with low dopamine D2 receptor availability in the striatum. Let's begin with our Education in Psychiatry feature by Carolyn Douglas, entitled Teaching Supportive Psychotherapy to Psychiatric Residents. She begins with a case vignette of a 45-year-old married teacher who is pursuing a doctorate in education. He feels stuck and unable to move ahead with his dissertation. His chronic, low-grade depression has worsened and now includes despair, extreme anxiety, insomnia, and trouble functioning at his teaching job. His wife urges him to get help after he begins to talk about an impulse to jump from their balcony. A second-year resident has been assigned to the patient. She admits to her supervisor that she already has a sinking feeling. The patient says he is too depressed to talk about his future. He also reports debilitating side effects from the antidepressant she prescribed and has warned her that he is sensitive to most drugs. The resident describes him as not just stuck, but sticky. She says she feels like she's wading in molasses. Few publications provide guidelines on how supportive psychotherapy should be taught. Much of the literature on supportive psychotherapy relies heavily on the language of psychoanalysis. Without some introduction to core psychoanalytic concepts, beginning psychotherapists can hardly be expected to understand what it means to manage the transference in supportive therapy and which patients require such management. Trainees also need to understand the differences between thinking psychoanalytically in providing support and acting like a psychoanalyst. Residents often feel compelled to explore the so-called emotional hotspots in the person's history. They have trouble understanding how a person can change in meaningful and enduring ways if these more conflict-laden issues are supportively bypassed in favor of the problems that are consciously on the patient's mind. What is supported in supportive psychotherapy is not simply a sense of safety, self-esteem, or hope, but deficient psychological capacities or ego functions. Residents should be encouraged to ask themselves what their patient's strengths are, as well as their vulnerabilities. Which ego functions are basically intact and which are deficient? Like most people, the patient in the vignette has a mix of personality strengths and vulnerabilities. His past history includes significant emotional trauma in childhood and suggests ego weaknesses in a number of areas. He has also recently lost his father and is currently in the midst of a life crisis. All of these are well-recognized indications for adopting a more supportive approach. At the same time, he has numerous strengths for which he has trouble giving himself credit. He is intelligent and is an accomplished athlete, a good teacher, and a loving husband and father. He has achieved a generally good level of ego functioning, which has now been temporarily overwhelmed in the setting of major depression, setbacks in his career, and in his father's death. Despite differences of opinion about theory and technique, there is general agreement that the main priority in supportive psychotherapy is to build a holding environment and to foster the therapeutic alliance. Residents sometimes err on the side of being too silent, passive, and opaque with patients they are treating supportively. Residents learning about supportive psychotherapy need to be encouraged to work actively from the very beginning to ensure that their patients' feelings of anxiety, shame, envy, anger, and despair are kept within tolerable bounds. Although transference is not a focus of supportive psychotherapy, residents should monitor the person's self-esteem and feelings about the therapist in treatment, and they should intervene quickly to repair any signs of rupture in the alliance. This should also be the supervisor's primary concern. The supervisor in the case vignette recognizes that the resident feels defeated. He tries to help her find some basis for liking the patient. The supervisor notes that in his experience, it is typical for someone who is seriously depressed to forget that he has ever had periods of better functioning, to overlook the things in his current life that are actually going well, and to have trouble in imagining that anything will ever alleviate the pain. The supervisor also reminds the resident that letting herself become affected by the patient's sense of urgency and panic will only increase his resistance. Typically, residents receive little guidance about how responsive and self-revealing they should be in therapy. The proper conduct of the supportive psychotherapist is a teachable interpersonal style best modeled in the supervisory relationship. Just as residents learn over time to offer their own lived experience as an object lesson for the person they are treating supportively, supervisors should feel free to share their own learning process, including any confusion and embarrassing moments they may have experienced. Like the people they are trying to help, residents often feel overwhelmed by the apparent enormity of the task they face. They may feel responsible for bringing about a total life overhaul in a relatively brief time. They need to be reminded that small improvements can lead to bigger changes, and that setting overly ambitious goals will only increase the likelihood of failure. The resident should be encouraged to enlist the patient's input in clarifying what sort of help the patient hopes the therapist might provide, and defining specific and achievable objectives for their work together. The supervisor in this case suggests that the patient is a proud man and seems to feel humiliated about his need for help. He suggests that the resident should view her role less as a cheerleader and more as a coach. While avoiding easy reassurances, she should continue to gently and tactfully challenge the patient's distorted beliefs about his incompetence, quietly comment on the ways he's helped himself in the past, and compliment him for his achievements. The supervisor models for the resident what it means to truly provide support, conveying an accurate understanding of the person's predicament, being empathetic, showing respect for and interest in the person, unobtrusively bolstering morale, encouraging mastery, and maintaining realistic hope for the two. Now we'll turn to the study by Graham Emsley and colleagues, Fluoxetine versus Placebo in Preventing Relapse of Major Depression in Children and Adolescents. The patients who had responded at the end of 12 weeks of acute treatment with fluoxetine were randomly assigned to receive fluoxetine or placebo for an additional 6 months. The patients were 7 to 18 years old. 50 received fluoxetine, and 52 were assigned to placebo. Most had met the criteria for remission after acute treatment, but approximately 10% only achieved response, which was defined as a clinical global impression severity score of 2 or less, plus a decrease of at least 50% in the score on the revised version of the Children's Depression Rating Scale. The participants were evaluated every other week for the first month of continuation treatment, and then monthly for the next 5 months. The primary outcome measures were relapse and time to relapse. Relapse occurred in nearly 70% of the participants in the placebo group and in 42% of the fluoxetine group. A multivariate logistic regression model was used to examine the effects of numerous demographic and clinical variables. The treatment effect was still significant, and it showed that the odds of relapse were 3 times as high for the placebo group as for the fluoxetine group. The survival curve for time to relapse was also adjusted for covariates. For the placebo group, the median time to relapse was 8 weeks after fluoxetine was discontinued. Fewer than 50% of the fluoxetine group had relapsed by this point, so the median time to relapse for the group could not be determined, although it was greater than 24 weeks. By 12 weeks, the estimated probability of relapse was 66% for the placebo group, compared with 36% for the fluoxetine group. The relapse rates were similar in the patients ages 7 to 11 and in those 12 to 18. The rates were also similar in males and females, but the impact of continued treatment with fluoxetine was greater in the males. Similarly, participants who had had residual symptoms at the end of 12 weeks of acute treatment were more likely to relapse during continuation treatment with either fluoxetine or placebo. Adverse events were similar in the two groups, and there were no discontinuations for this reason. 3 serious adverse events occurred during the continuation phase. 2 participants in the placebo group were hospitalized for pre-existing medical conditions, and 1 participant in the fluoxetine group was withdrawn after a suicide attempt at week 16. This patient had a history of self-injurious behavior and suicidal plans without intent prior to acute treatment with fluoxetine. Next, we'll highlight the study by Nancy Bloom and colleagues entitled Systems Training for Emotional Predictability and Problem Solving for Outpatients with Borderline Personality Disorder, a randomized controlled trial and 1-year follow-up. The acronym used for Systems Training for Emotional Predictability and Problem Solving is STEPS. It's a 20-week manual-based group treatment program for outpatients with borderline personality disorder. STEPS combines cognitive behavioral elements, skills training, and a systems component. Family members and significant others participate in a session on how to respond to the patient. In this study, STEPS was provided as an adjunct to treatment as usual. 65 patients received the combination, and 59 received treatment as usual without STEPS. They were followed for up to 1 year after the end of treatment. At the end of treatment, the patients who had received STEPS plus treatment as usual had greater improvement in the total score on the Zanarini rating scale for borderline personality disorder compared to patients who had received treatment as usual only. The patients in the STEPS program also had greater gains on the subscales for impulsive, affective, cognitive, and interpersonal domains. In addition, most of these improvements were maintained over 1 year of follow-up. There were no differences between groups in suicide attempts, active self-harm, or hospitalizations. However, fewer of the patients in the STEPS program had visits to the emergency department during treatment and follow-up. Kenneth Silk examines treatment for borderline personality disorder in his editorial, Augmenting Psychotherapy for Borderline Personality Disorder, the STEPS program. He refers to the thoughts of helplessness and hopelessness conjured up by the diagnosis of borderline personality disorder in the treatment providers as well as patients. Much has changed in the last 10 to 15 years, but unfortunately too many therapists still feel that borderline personality disorder is untreatable and is a lifelong drain on the energy of the therapist, the psychopharmacologist, and the entire mental health system. Substantial research now sheds light on many of these assumptions. There is strong evidence from the McLean study of adult development that 40% of patients with borderline personality disorder remit after 2 years, with 88% no longer meeting the diagnostic criteria after 10 years. Even more surprising and myth-debunking is the number of well-designed controlled studies in support of effective treatment for borderline personality disorder. Most of these studies are randomized controlled trials of therapies that range from cognitive behavioral to psychodynamic and psychoanalytically based therapies. It is interesting that most of these interventions are in the non-pharmacologic arena, while psychopharmacologic treatment of borderline personality disorder remains unclear, uncertain, and in general unimpressive. What is intriguing about the study by Bloom and colleagues is that this non-pharmacological intervention is essentially an augmentation of treatment that is already occurring for patients with borderline personality disorder. While the STEPS intervention did not detect significant between-group differences for suicide attempts, self-harm, or other measures of crises, the importance of the intervention should not be diminished. There are a number of treatments for borderline personality disorder that do decrease self-destructive behavior, but some of those that improve suicidality do not necessarily improve depression any more than the control intervention. It would appear sensible to use STEPS as an adjunct, particularly to an intervention in which effectiveness is limited in areas where STEPS has been shown to be beneficial. Perhaps as we study the impact of specific and different psychotherapeutic interventions, we may be able to combine or sequence various interventions to get a greater degree of the effectiveness of psychotherapy. For example, in the case of dialectical behavioral therapy, where the impact on depressed mood is not impressive, the strategy of augmenting the treatment with STEPS might provide more extensive overall benefit. In addition, STEPS has a systems component. There is a need for more interventions that involve the systems that surround the patient with borderline personality disorder. It is often the people who interact with the patient who remain perplexed and stymied in responding to their patient, friend, or relative with the disorder. The STEPS study is a well-designed effectiveness study and was carried out in a thoughtful way. In addition to the randomization, the study is also naturalistic in that outside psychotherapeutic and psychopharmacologic treatment was not controlled, other than the requirement of having an outside therapist. It is to the researchers' credit that they were able to combine the best elements of a randomized controlled trial with this naturalistic aspect of ongoing treatment. Glenn Gabbard has suggested that we should be cautious not to pit one therapy against another in an attempt to find the very best. What is so helpful about having STEPS in our therapeutic black bag is that it complements other therapies and need not replace or compete with them. The greater the number of available effective interventions, the better the chance that a patient may be able to improve to a degree where she feels that life is once again worth living. Then we will have more evidence to erase the myth that borderline personality disorder is untreatable and that the diagnosis relegates the patient to a life of helplessness and hopelessness. This concludes the editorial by Kenneth Silk. Now we'll turn to the topic of schizophrenia. Takanori Hashimoto and colleagues report conserved regional patterns of GABA-related transcript expression in the neocortex of subjects with schizophrenia. They examined whether the altered expression of genes affecting the neurotransmission of GABA-aminobutyric acid is restricted to the dorsolateral prefrontal cortex in schizophrenia, or if it could also contribute to the dysfunction of other cortical areas. Post-mortem brains of 12 subjects with schizophrenia and 12 matched normal subjects were used in this study. The levels of 8 GABA-related transcripts were measured in 4 cortical areas: the dorsolateral prefrontal cortex, the anterior cingulate cortex, the primary motor cortex, and the primary visual cortex. Messenger RNA for each of the 8 markers was measured by means of a polymerase chain reaction. Expression levels of 7 transcripts were lower in the subjects with schizophrenia, and the magnitude of the reduction for each transcript was comparable across the 4 brain regions. The largest reductions were detected for mRNA encoding somatostatin and parvalbumin. There were also moderate decreases in expression of the 6-kilodalton isoform of the glutamic acid decarboxylase, the GABA membrane transporter GAT1, and the alpha-1 and delta subunits of GABA-A receptors. In contrast, the expression of calretinin mRNA did not differ between groups in any of the 4 brain areas. In our second schizophrenia article, Monica Rice and colleagues report excessive brain volume loss over time in cannabis-using first-episode schizophrenia patients. They performed MRI scans of the brains of 51 patients at 2 time points, during the first episode of schizophrenia and again at 5-year follow-up. 19 patients used cannabis but no other illicit drugs during the follow-up period, and 32 patients did not use any illicit drugs during this time. Healthy comparison subjects also received 2 scans at comparable times. Over the 5-year follow-up, the patients with schizophrenia who had used cannabis had a greater reduction in the volume of cerebral gray matter compared to both the patients who did not use drugs and the healthy subjects. They also showed larger increases in the volumes of the lateral and third ventricles. The cannabis users also had less symptomatic improvement than the non-users, but functional outcomes and days of hospitalization were similar in the 2 groups of patients. The significance of the findings in these 2 articles is examined by Editor-in-Chief Robert Friedman in his editorial, Cannabis, Inhibitory Neurons, and the Progressive Course of Schizophrenia. Diminished brain size has long been recognized as a common feature of schizophrenia. The number of neurons appears to be intact, but there is a loss of the axons and dendrites that connect the neurons with each other. If the pathophysiology of this loss were better understood and could be arrested, individuals with schizophrenia might be spared the cognitive and social decline that occurs over the course of the illness. The Hashimoto and Rice articles provide further evidence about the loss of neuron function and structure in schizophrenia. Hashimoto and colleagues present data that increase the evidence for loss of inhibitory function in interneurons throughout the neocortex in schizophrenia. The diminished expression of GABA-related genes in all 4 brain regions suggests that the cerebral cortex of individuals with schizophrenia lacks normal inhibitory neuronal machinery. Deficits in inhibitory neurons in schizophrenia have been found by a number of investigators in various brain regions. This study is the first to present evidence that the deficit is widespread throughout the neocortex. In the second article, Rice and colleagues used MRI to document that patients with schizophrenia who used cannabis during a 5-year interval lost tissue at nearly twice the rate of patients with schizophrenia who did not use cannabis during this interval. We do not know for sure if cannabis abuse is the causative agent or if the loss of brain tissue due to the illness causes patients to abuse cannabis. However, the cannabis abusers and non-cannabis users did not differ in brain size or psychopathology at the initial examination, which suggests that cannabis is the causal agent. Why would individuals with schizophrenia want to use cannabis, which further decreases inhibition of the cerebral cortex, when they are already losing inhibitory interneuron function? Functional MRI of brain activity demonstrates that neuronal activity is decreased in the frontal lobe of many patients with schizophrenia. When they are asked to complete a task, these patients often respond with increased activity over a wider area of the frontal lobe compared to normal subjects. Patients with schizophrenia appear to need to increase their brain's excitatory activity to compensate for other deficits in brain function. If cannabis blocks the release of GABA, the result is that their brains are more readily excited. Cannabis may therefore help individuals with schizophrenia achieve the more widespread levels of excitation in the frontal lobe that are required to match the performance of other individuals. Unfortunately, the loss of inhibition causes problems. Inhibition normally supports cognitive function by helping neurons attune themselves to only respond to target stimuli of interest and to inhibit their response to extraneous or distracting material. Individuals with schizophrenia already have hyperactive sensory and limbic areas. Further loss of inhibition in these areas may contribute to distractibility and the inability to distinguish between internal and external stimuli. Thus, cannabis use has been associated with exacerbation of psychotic symptoms. There are further long-term consequences of prolonged cannabis use. Excitatory neurotransmission between neurons is the mechanism by which one neuron changes the activity of another in the service of conveying and processing information. However, excitatory neurotransmission works by admitting sodium and calcium ions into the neuron. In large amounts, these ions are toxic and can stress the neuron, resulting in loss of neuronal functions, loss of dendrites, and ultimately cell death. This process is called excitotoxicity. The mechanism of neuronal stress in schizophrenia is unknown, but excitotoxicity is one possible mechanism. Activation of cannabinoid CB1 receptors generally has a neuroprotective effect, but chronic exposure to cannabinoids desensitizes cannabinoid CB1 receptors. The desensitized receptors, then, can no longer help protect neurons against the stress of increased excitation. These new data suggest that cannabis should now join nicotine and alcohol as substances that have long-term negative consequences which patients and their families need to understand. Information about these negative effects and treatment for cannabis abuse seem warranted as one of the few things that psychiatrists can do to help patients with schizophrenia prevent further decline in cognitive function. Next, we'll shift to the genetic association study by Alan Sanders and colleagues entitled Association of 14 Candidate Genes to Schizophrenia in a Large European Ancestry Sample, Implications for Psychiatric Genetics. Association of these genes has been shown previously but has not been firmly established. The authors applied uniform clinical methods to assess a large number of subjects and used a comprehensive set of single nucleotide polymorphisms referred to as SNPs. They recruited cases from 3 related studies, and the analyses included more than 1,800 people with schizophrenia or schizoaffective disorder, as well as 2,000 comparison subjects. Dense sets of SNPs were tested in each gene rather than just a few. These included tags for most known common SNPs, plus additional SNPs in critical gene elements, such as those that change amino acid sequences. Nearly 650 SNPs were analyzed for association of single SNPs and of haplotypes, which are combinations of SNPs. Neither experiment-wide nor gene-wide statistical significance was observed in the primary analyses of single SNPs. Significance also was not found in the secondary analysis of haplotypes. 70 SNPs had been chosen for testing because previous evidence suggested they were associated with schizophrenia. 4 produced nominally significant p-values, but this number is consistent with chance expectation. The authors point out that a role for any of these genes in schizophrenia cannot be definitively ruled out. Many of the odds ratios for association are in a plausible range for small susceptibility effects, but are below what would produce significant p-values in this sample or in the smaller samples used in previous studies. Also, only the hypothesis of association to common SNPs has been tested in a reasonably systematic way. More will be learned from future studies using resequencing methods to detect rare SNPs and genome-wide SNP arrays to detect genomic deletions and insertions, as well as large-scale analyses of gene-gene interactions. Also, genome-wide association studies of large samples provide more powerful and systematic tests of common SNPs and of insertion-deletion variants throughout the genome. They have already produced robust replicable association findings for other complex genetic phenotypes. Our final article is by Christoph Fair and colleagues, who report an association of low striatal dopamine D2 receptor availability with nicotine dependence similar to that seen with other drugs of abuse. Like other abused substances, nicotine provides a sustained dopamine release in the nucleus accumbens. Studies have examined whether this is associated with a decrease in the brain's dopamine functions. In the ventral striatum and caudate of chronic smokers, dopamine D1 binding potential has been shown to be lower than in non-smoking subjects. Fair and colleagues tested D2 receptor availability, which is already known to be low in patients who are dependent on alcohol, heroin, cocaine, or methamphetamine. Similar differences were expected in patients with nicotine dependence. The study used PET scans with the ligand 18F-phallopride, which has a high affinity for D2 and D3 receptors. All of the subjects were men. 17 were smokers who consumed more than 15 cigarettes a day. The 21 comparison subjects had a maximum lifetime consumption of 20 cigarettes. The smokers were scanned twice. The first was during a period of regular smoking. They were asked to smoke their average number of cigarettes on the study day and not to stop until they were lying in the PET scanner. The second scan was performed 24 hours after smoking cessation to examine functioning during withdrawal. The two scans of the smokers during smoking and withdrawal conditions showed similar dopamine receptor availability. At both times, the smokers had lower receptor availability in the bilateral putamen than the non-smokers. This difference was not related to the severity of nicotine dependence as measured by scores on the Fagerstrom test for nicotine dependence. No difference between groups was found in regions outside the striatum, and there was no area where D2 and D3 receptor availability was higher in the smokers than in the non-smokers. Nicotine craving was measured with the questionnaire on smoking urges. Contrary to expectations, the rating of craving in the smoking condition correlated positively with the D2 and D3 receptor availability in the ventral striatum. On the other hand, craving correlated negatively with receptor availability in the anterior cingulate and inferior temporal cortex. Together, the results imply that nicotine craving during ordinary consumption is maintained by a region-specific shift in D2 and D3 receptor availability, with greater availability in the striatum and less availability in the anterior cingulate cortex and inferior temporal cortex. Lesion experiments in rodents have indicated functional subdivisions in the midbrain dopamine system. The shell of the nucleus accumbens mediates the effects of psychostimulant drugs, and the core is important for priming cue-induced drug craving. Functional subdivisions have also been proposed for the human striatum, but in this study and an earlier study of cocaine-dependent subjects, low ligand binding was observed within all three parts of the striatum: the limbic, associative, and sensory motor regions. Thus, nicotine-induced alterations are not limited to the regions mediating unconscious drug seeking. Presumably, they also affect regions that initiate drug stimuli conditioning, as well as the psychomotor effects of nicotine stimuli. This concludes the audio highlights of the April issue of the American Journal of Psychiatry. We invite you to refer to the online issue at ajp.psychiatryonline.org for the full text of these and other articles. We also welcome comments regarding this audio. They can be emailed to Jane Weaver. Her email address is jweaver@psych.org. Thank you.